ucabanga kanjalo le
asikwazi ukuthi ama-leaders we-HIV ahlale ngasemuva wabona PLHIV Sector
ya abanikazi bendawo
abanikazi bengculazi ngamanekili
namanye amalele nje so
ngishintshela le ndlela ukuthi
nje yes so
usho ukuthi lokho sisithanda nokukhula kuhlehle phela uyahamba ngiyakela ukuyale ungangami sishiyelana impahla intombi manje sishiyelana impahla makafika endlini nje uvela athi wardrobe yami mamthi ngilinganisele ngithi ayayayay
kodwa ngicela kudlula
umuntu ngathi sikamanje
okay madam
right special school
There we go.
the Down syndrome special school
Thanks.
yo siyaba ikipa laphezulu nje sentence
Okay.
uvela ewardrobe yami athi mama ngicela ngimhlale ngithi athi nakucela athathe nento zami engazi ukuthi le ngigqoka nale ngigqoka
Hi.
ujuna nje sibhalile uyibheka biometric simele ama-results isile ntombi abantwana bami bakhulela ingculazi
ungekho endlini
uyazi ngisho kodwa uyiphephe manje sikhuze nogogo ntombi siyakhuza nje next week
wena
yeah
oh hey no I was in the like yeah sure I was standing there she jumped you never shut up never shut up instead calling
One. 4. I mean, I'm not a steering committee. Uyangifaka.
Yeah, get it.
okay Oh, tozabelo. Good morning, Sanbonani. The room is so empty. Nonhlanhla, is it possible for you guys to come a bit forward? Kanyisa. Ganceng. Because I go so empty and must bona ma leaders la phambi kwethu at least. Siyakhuthala. Colleagues, this is a very exciting moment for us as people living with HIV. We are here today to launch a Stigma Index 2.0. I think people who have worked with us on this, they know how difficult it was. The fight behind it, the push, the advocacy, and everything that was happening behind the scene. But at least today we are here. The product is final. We are here to launch the 2.0 Stigma Index. The results are very shocking sometimes, others are relieving, siphakathi nendawo to say, oh, wow, this is still happening. As we are working on the ground, some of the things we know that they are happening in just general based on the work that we are doing. But once now you start to put percentage and numbers, then you start to see the seriousness of the challenges of stigma that we are still facing. And especially in 2025, we never thought as people living with HIV that will be here. We thought by this time we'll be not even talking about stigma the way we tried to address the issues of stigma and the way we tried. I'm saying we tried purposely because it means we have not done enough to educate communities about stigma and discrimination. But unfortunately, today here we are. But that doesn't mean that we need to sit back and say, no, sihlulekile. We have not failed. We have worked. That is why we will see these good results also. But it means we still have more work to do. So I don't want to waste so much time. I want to introduce my co-moderator, Ubabu Professor Dr. Just unazo zonke lezi titles and urev ngaphezulu, and he's a man living with HIV. So uyikho konke kukho konke. Umyeni kaSisichuma i-ex yami ke yabo. Yeah, ngicela ningamangali masihleka kakhulu la nithi and then laba bayenzani noSisichuma uyazi ukuthi kunobu ex nyana obukhona phakathi. This is Rev Prof ngikubiza kanjani Prof Rev okonke lokho Jasi Mbulelo Jasi. Yeah, I want to acknowledge and thank you all of you who are here. Introduction, it would be a bit difficult for me, but I want to at least start by asking my colleagues here on the front, but in the room we are not much. My challenge will be online because last time we checked, we had about 64 people, so it will be very difficult to allow them to introduce themselves. But we've asked them to write on the chat so that we can be able to acknowledge people online. Maybe I should start with you, my lady.
Sanbona endlini, my name is Nompumelelo Wagwazungu, and I'm sometimes called Mpumi from the HSRC.
Yabona it's a simple mine monopausing ne aging inkinga. I'm looking at you, I want your name, but I'll pum. Apologize. You can come, my sister.
Sanbona igama lami nguTebogo wakwaGumede Mazwai from HSRC.
Siyabonga.
Good morning, colleagues. My name is Bongani Matomela. I'm from the United Nations Development Program.
Thank you.
Good morning, colleagues. My name is Chris van Rooyen. I'm from the National Department of Social Development.
Morning, Masilo Marumo from PEFA.
Tabela, Konera Patlelo from Limpopo PCA and also from the Oversight Committee CCM.
Good morning. I'm Musa Manganye from NDOH. Thank you.
Thank you. Mluleki.
Hey.
Wona no deputy wako niyaphikisana.
Morning, colleagues. Mluleki Zazini, the chairperson of the SANAC PLHIV Sector. Thanks.
Morning, everyone. Tandi Maluka from Positive Women's Network and the Deputy Chairperson of the PLHIV Sector. Thank you.
Thank you.
Good morning, everyone. My name is Duncan Mwekeze and I'm from NAPWA. Thank you.
Good morning, colleagues. My name is Godfrey Lepono. I'm from Treatment Action Campaign and one of the project managers or project managers.
Thank you.
Good morning. My name is Patrick Wadula. I'm with the CSF, the Disability Sector. Thank you.
Katleo.
Hi, my name is Katlego. I'm with the National Sex Worker Sector Leadership and with the Global Fund and the Oversight. 2028, my leadership is coming to an end.
Morning, everyone. My name is Kanyisa Dunjwa. I am with the SANAC Civil Society Forum and I belong to the Women's Sector.
Morning, everyone. It's Sean Wester and I'm from the Human Sciences Research Council.
Tobela, Litlogonolo Makula, Women's Sciences Research Council.
Good morning, colleagues. My name is Yolandi Sheen from the Human Sciences Research Council.
Good morning, colleagues. My name is Molaro Morudi from COSATU, co-chair CCM Global Fund. Thanks.
Thokozani kamala Mushila wakampele ngumhlali wala ekuruleni. I'm the first deputy chair from SANAC Civil Society ngiyabonga.
Good morning, everyone. My name is Noxolo Mguni. I am from Nakosa.
Good morning, everybody. I'm Dr. Jacqueline Matthews. I participate today as part of CCI.
Morning, colleagues. Class M20 from the People Who Use Drugs subsector, Civil Society. Thanks.
Good morning, colleagues. I'm Dineo Rangwanana from CCI, the National Program Officer under Human Rights and Gender. Thank you.
Good morning, everyone. I'm Mariatu Elba. I'm the Human Rights and Gender Technical Lead at Center for Community Impact. Thank you.
Sibingelele, colleagues on site and online, part of CSF, the LGBTI sector.
Morning, everyone. My name is Tsuegam Tetwa, part of the National Disability Sector, the CSF, as well as the Coordinating Committee. Thanks.
Absheni, my name is Tumisan Mandlope, Research Sector Chairperson, Civil Society, Gauteng. Thank you.
I'm not sure whether colleagues at the back, do you want to introduce yourself? I think it's very important for us to know who is in the room. Let's start up Pagu Nelson.
Good morning, everyone. It's Nelson Dlamini from the SANAC Secretariat. Thank you.
Morning, colleagues. Karao Makhatu from SANAC. Thank you.
Morning, colleagues. My name is Adziliwi Nematandani from Human Sciences Research Council. Thank you.
Good morning, colleagues. My name is Patricia Fasache. I'm from the SABC.
Good morning, colleagues. Tabo from HSRC. Thank you.
Good morning, colleagues. Antonio Erasmus from HSRC. Thank you.
Good morning. My name is Mpikelelo. I'm with the NRF.
Good morning. My name is Polo Ramotwala from SANAC Technical Support Unit responsible for human rights. Thanks.
Morning, colleagues. Shandi Ramligan, HSRC.
Thank you very much, colleagues. Let me acknowledge my chairperson for Civil Society Forum, Ubabundugu. He's entering the room. Welcome, Babundugu. Because you're just entering the room, I'll give you time to settle. Babundugu ngicela uze ngapha phambili. Kahle kahle ngicela ne-coordinating committee ize ngapha phambili. Leaders of Civil Society Forum. Kunama reserve chairs la are empty. Ngiyacela. So that sinibone ukuthi ngama leader wengculaza. So because chairperson of civil society, he just came in, I will give him time to settle in and relax so that he can be able to give us the opening remarks. Let me give the HRSC for now the platform to give us opening remarks. Sisimpumi, you're welcome.
Okay, there we go. Good morning, everybody. Sanbonani. Ninjani. Nkhona. I didn't know ukuthi kuzoqala mina, but you must always be ready in all seasons. So I am ready. Let me take the opportunity to thank the sector, the leadership of the sector, and everyone who has joined us this morning. It is really an honor for me to be asked to say a few words on behalf of the Human Sciences Research Council. Distinguished guests, colleagues who are in the room, respected members of the HIV and AIDS community and all the allied sectors, partners, the media, and also friends who are in the room. In the interest of time, I know my chair has introduced some of the leadership, and allow me to stand on that protocol. I would like to begin my opening remarks by quoting Dr. Rolihlahla Mandela in his address on the 1st of December 2006. And he says, one of the greatest challenges we face is the gaping and growing disparities in the response to HIV between countries and regions around the world. AIDS-related stigma and discrimination are pervasive and a real barrier to stopping the expansion of this disease. Close quotation. As we gather in 2025, I reflect on these words, and as you maybe have listened to them, they sound like we are in 2025, and this is something that was said in 2006. I think as a sector and researchers working within the HIV research area, we note that while we've made considerable progress in the fight against HIV, persistent challenges and new threats have a potential of derailing our progress. The launch of the Stigma Index 2.0 marks a significant milestone in our collective efforts to end HIV as a public threat by 2030. Since 2002, the Human Sciences Research Council has played a vital role in advancing our understanding of HIV and stigma through rigorous research. This body of work has served as a cornerstone for informing policies, programs, and community interventions designed to reduce stigma and discrimination experienced by people living with HIV. Since the early days of the epidemic, the HSRC has been a trusted leader, but also a partner to the sector. We've conducted studies that have captured the lived experiences of people living with HIV, but also those that are affected by HIV. Our research has highlighted how stigma undermines access to HIV testing, treatment, psychological support, and ultimately how it affects the health outcomes and also well-being of the people living with HIV. So the index is a legacy, number one, but it also incorporates the work that we have done over the years using updated tools and methodologies and reflects the current context while addressing the emerging challenges that we face, especially those that are related to stigma, discrimination, and also human rights. This effort has been made possible through strong partnerships, and most of the partners that we've worked with since the beginning are around the room. A broad range of stakeholders across government, civil society, and also the HIV sector. The collaboration between the people living with HIV sector, SANAC, the steering committee, the HSRC, and many dedicated organizations has ensured that the study that we're going to launch this morning is grounded both in scientific rigor, but also community participation. This collective approach has strengthened the relevance and impact of our research as the HSRC, but also of the index that we are going to share today. The recommendations that will come out of this report or the study are both actionable for policymakers, for service providers, and sector advocates alike. As we launch this important new phase of the Stigma Index that is led, and I want to emphasize and underline that point, that is led by the sector. The HSRC has been subcontracted by the sector to provide only technical support, while the sector is led from the front, as you can even see today. We reaffirm our commitment to generating evidence that drives social justice and also inclusivity. We look forward to continuing this collaborative journey with the sector to dismantle stigma and create an environment where everyone affected by HIV can live with dignity and respect. Let me conclude my opening remarks by again quoting Dr. Mandela. And this is a speech that he gave at the 4664 South Africa concert that was in George on the 19th of March 2005, where he says the campaign against AIDS is the task of all of us, young and old, government and community organizations, religious and traditional institutions, cultural and sporting bodies. AIDS knows no custom, it knows no color, it knows no boundaries. We have to work together wherever we are to preserve our nation, our continent, and community as a whole. I thank you.
Thank you very much, Mayor. We really appreciate your opening remarks. I don't know whoever was behind this meeting. You made a mistake of allowing me to co-chair with my ex-wife. But we'll manage our issues. We won't even notice that there are outstanding issues. Thank you very much, colleagues. Let me also welcome all of you to this very important meeting this morning. Ubabunduku, umuhle mkhulu namhlanje. I like your shirt, mkhulu. You are handsome. Let's allow Babunduku to come and also welcome us and also render opening remarks. Thanks so much, Mkulu.
Sanbonan. Dumelang. Molweni. Good morning. Co-directors of proceedings, the steering committee members for the Stigma Index 2.0, led by Comrade Thandi Maloga, leaders from the PLHIV sector, member organizations, the representatives and leadership of NAPWA, HSRC team, the National Department of Health, Social Development, UN development agencies, and the other development partners. The delegates and technical support unit, SANAC Secretariat, led by Dr. Kolo in absentia, members of the media in attendance. Most importantly, people living with HIV from every corner of our country and globally. It is an honor and privilege for me to join you today for this important moment in our national HIV response, the launch and dissemination of 2024 People Living with HIV Stigma Index 2.0. Today we are not merely releasing the report, we are reaffirming a commitment to dignity, to justice, and to building a South Africa where every person living with HIV can live openly, safely, and free from stigma and discrimination. The study, led by PLHIV Sector and coordinated by NAPWA, with the technical leadership of the HSRC and SANAC, represent one of the most significant community-led research efforts in our country. It forms part of global initiative driven by the Global Partnership of People Living with HIV and UNAIDS, and many internal and international allies who share a united vision to end stigma everywhere for everyone. Comrades and colleagues, the strength of this study lies in its authenticity. It captures the voices of more than 5,000 people living with HIV, women, men, young people, key populations, urban and rural communities, across all the 9 provinces and across 18 districts of our nation. These voices reflect lived experiences, daily realities, challenges, and triumphs. And they remind us that behind every statistic is a human being with a name, a story, and a right to dignity. The findings we are launching today will strengthen our advocacy and help shape national HIV policies that respond to the real needs, guide targeted interventions that seek to address the root causes of stigma and discrimination, advance a more inclusive and dignified HIV response where no one is left behind. As the SANAC Civil Society Forum, we welcome the findings because they give us evidence to push harder, to challenge the systems that still fail our communities, and to hold ourselves accountable for creating a safe and affirming spaces for people living with HIV. But today is also about opportunity. That data before us highlights not only persistent barriers, but also the pathways for positive change. Stronger human rights protection, better community-led monitoring, more responsive health systems, and deeper integration of people living with HIV leadership in decision-making at every level and every sphere. I want to extend my appreciation to the very field worker, every community organization, every provincial, district, and local structure, and every partner who ensured that this study was not only possible, but credible and community-owned. Most of all, I want to honor our people living with HIV who participated, who trusted us with their stories. Your courage is the backbone of this report. As we engage with the findings today, let us do so with purpose. Let us commit that this report will not gather dust on the shelves. It must lead to action. It must lead to accountability. And it must lead to a South Africa where stigma and discrimination are not tolerated in our clinics, in our facilities, in our communities, in our workplaces, and in our settings. In conclusion, fellow comrades and compatriots, together we can end stigma and discrimination. Together we can build a future where people living with HIV thrive with pride, visibility, and full respect. I thank you. Aluta.
Thank you very much, Chair. Before I request Department of Health to join us here, for the first time in the history of South Africa, that we have such a powerful data that belongs to people live with HIV. It's not your data, Department of Health. This data belongs to people who live with HIV. And if you need this information, you must write to us immediately. I mean now, immediately, not in the future. Welcome, Department of Health.
Co-moderators, allow me to rise on the protocol that has already been observed. as I greet you this wonderful morning. Prof, consider it done. We will truly do so. Data needs to be used and needs to be acknowledged, and we truly are excited that it is available, because then it will not only be lying on our shelves, but we need to use that for the maximum benefit that it is actually intended for. As we start with our remarks, I'm reminded of this social media content influencer. It's called Tumelo Trom, and you always say, we are very excitement. And I think that actually demonstrated the essence of the kind of performance his team is actually demonstrating currently. So I would like to really ride on the same wavelength of our excitement actually in terms of the level within which the PLHIV sector has led and demonstrated its leadership in terms of making sure that we get to a point where the HIV epidemic is no longer a public health threat. And we need to actually realize that with no delay. And we are affirming our commitment to that. We recognize that the Stigma Index 2.0 is actually rode on the updated tool, which really was an original tool to measure the stigma and discrimination that are faced by the people living with HIV. We are equally considerate and very much applauding the fact that the essence around the sample that was actually used is actually demonstrated the representation that can actually affirm where this response in terms of mitigating around the stigma and discrimination is headed, and especially in terms of the experience, the lived experience that has been actually affirmed by the people that actually participated largely in this study. So with that said, we believe that it is actually going to all the depth that would actually enable us to make sure that we're able to respond with swift. But we do have questions that we need to ride on, especially in terms of what does this report and the launching of the report actually means to us as the government and the other government ministries, because it's not only limited to health in particular. There are social issues and ills that we need to actually recognize. There are other structural barriers that are not only limited to the Department of Health, that we must also acknowledge that actually stems the direction within which the response has to be leveraged. So what does it mean to us as the Ministry of Health? We recognize this as a tool that would actually demonstrate the evidence towards where we shift on a policy response and the guidance within which we are able to make sure that the response is not actually based on where we think we should be headed, but it is based on what the needs are for the people living with HIV, which is actually central to the discourse that we are working on. We believe that it will actually enable us to make sure that despite all the medical advances and the response that we had made, all the social and structural barriers that continue to undermine the access of the services for many people living with HIV would actually need to be realized, that we need to make a shift and make sure that we're able to respond, not only because we are mandated to, but because it is actually a necessity for us to make sure that we respond accordingly. This would actually highlight critical interventions that we need to also make sure that they are more targeted in order to make sure that all the sectors that are involved are able to ensure that we leverage the delivery of the healthcare services and also other social contexts that we need to actually make sure that we continue to realize as a need for people living with HIV. But in practical, what does it really mean? For us as policymakers and the implementers on the ground, the data that has been identified and found within the study would actually give us more updated and the national representation on the picture of where the pain points are in terms of the stigma and how do we tailor our programs to respond swiftly. It is also an ideal realization that the healthcare services would need to be strengthened without any discrimination, would need to be strengthened with more inclusivity, would need to be strengthened in rising astray and far away from the marginalized realizations that we had seen over some time that people living with HIV had actually experienced. But it also calls on the communities to actually realize the hope that we had actually lived and we had captured in so many instances in order to translate to the real improvements, which is less of the judgment, which is less of the inaccessibility of the healthcare services that we know that they do are available within our healthcare facilities. But as I end and as we continue to accept the results that are going to be presented in this platform, we do have questions that we need to ask. And these are questions that are skeptical, these are questions that must be asked, and these are the questions that we need to actually inform. How do we actually respond to them? Having the report is one thing, but will the government, will all the sectors, will all the people that are actually supposed to actually act on these findings? Will we have this evidence become yet another document that is actually gathering dust? And I don't think we need to get to that. Will these interventions that are going to be committed to reach the most marginalized people, especially in our rural communities, disabled people, as well as the key population? And will it actually enable that we mainstream this within our respective programs? Can the stigma and the discrimination reduction be actually beyond health, beyond any other sectors, so that we can actually realize the essence of the inclusivity and everyone collectively to actually realize the mutual accountability in terms of our response? Are the voices of the people living with HIV, including those that are marginalized groups, empowered sufficiently to the design and the implementation, the monitoring, the accountability, and the evaluation of the very same interventions that we'll be actually doing? Because it shouldn't be, yes, we have a report, let's hand it over to you, then go implement. It needs to be a collective effort where everyone, in every step, in every process, we are fully involved so that we can actually maximize the representation, the accountability, the ownership, and most importantly, the change and the improvement that we want to realize. So we are thanking all the leadership for making this possible, and we believe that we're going to ride together to make sure that there is implementation, and we can commit from the Ministry of Health that this is part of our priority, and we are determined to respond in order to make sure that we reduce the stigma and discrimination. Thank you.
Thank you very much, Dr. Mosa. You have touched on very important points, especially when it comes to collective accountability and the work that we need to continue to do, all of us, people living with HIV, all departments and everyone. You know, as we are aging, you know, my ex and others in the room, we are starting to experience a lot of NCDs. And that is a conversation we are having now, which we would like also Sisimpumi to assist us to lead on that, to check what are the things that people living with HIV are living with and what are the challenges that we are facing. We know what we are facing, but when you speak just about them, not putting data, not putting numbers into it. About Dr. Musa, they tend to say, no, man, baba ngumsindo. But once you give them the tangible data, and we've learned as communities that we can use data, and to use data, it gives us a full understanding. Also, we are able to advocate having tangible numbers to say these numbers means that these people, this is what is happening. So I think now we need to head to that, because we are aging, and we are proudly aging, because we never thought that we will be aging with HIV. I think most of us who started ARVs very early, we never thought of 50. We thought lapako 40 so will die. But today we are living and it's healthy. But now our NCTs, sikakeki, la monopause, so now it's a time for our presentation, Stigma 2.0 launch, which will be led by our own chairperson of people living with HIV, and Duncan Muyeketsi, who's the principal investigator. Because we are in this moment, Prof. Rev. Dr. Kasimsumi Sengengoma man.
Good morning, everyone. My name is Mluleki Zazini. I'm the National Director for NAPWA, also the Chairperson of People Living with HIV Sector, and the second Deputy Chair for SANAC Civil Society Forum. Lelo, I never thought that this day will come. It's a pity I don't see Dr. Mlungisi here, but there are colleagues from SANAC and leadership PLHIV sector. Comrades, it was not an easy exercise for this journey. But I think as people living with HIV, we need to celebrate this day. We need to celebrate it. Because it is not usually that people living with HIV are given that recognition, especially on issues related leading studies. I think we need to applaud ourselves. But without wasting any time, let me focus on the presentation that I will be co-presenting with comrade Tangen, who was the co-principal investigator for this study. Our presentation will focus on the background of the Stigma Index 2.0, the main objectives of the Stigma Index, study methods, key findings, recommendations, and advocacy plan. Sure. On a background, the PLHIV Stigma Index 2.0 is a global standardized tool designed to measure the impact of stigma, discrimination, and human rights violations of people living with HIV. This was designed by people living with HIV for people living with HIV. In terms of the purpose, it serves as a vital instrument for policy influence and advocacy efforts, because once we have produced some results for stigma index, then we are able to take issues to inform policies and to make sure that we develop some advocacy interventions to respond to these findings. In terms of the evolution, the first stigma index was launched in 2008 and revised in 2018 to adapt to evolving epidemic landscapes. A standardized methodology was introduced in 2020, hence EGNP Plus at a global level kept guiding us to make sure that we adhere in those global standard methodologies. Then the PLHIV-led initiatives, the index is conceptualized, implemented and driven by people living with HIV themselves, embodying the principles of greater involvement of people living with HIV and AIDS, which is the JIPA principle. This empowers local PLHIV networks to lead the studies fully implementation. I am aware, Comrade Pulu, you guided us that PLHIV sector, making sure that we have ownership for this study. You need to make sure that those global non-negotiables we adhere as South Africa. With that support, Comrade Pulu, as the PLHIV sector, we did that advocacy and we are allowed to take a lead as the sector. The PLHIV Stigma Index, sorry. South Africa has been a proactive participant in the Stigma Index initiative, conducting prior to understand and address the unique challenges faced by people living with HIV in our nation. Then in terms of previous surveys, the first two stigma indexes in South Africa were conducted in 2014 and in 2020 through a collaboration efforts between the Human Science Research Council, people living with HIV sector, and SANAC. We do understand that in 2010, NAPWA was supported by a global network of people living with HIV in the country to pilot the stigma index, where one of the recommendations was that let's have a national stigma index. And then the country supported us to have the first one in 2014. In 2024 leadership, the 2024 stigma index 2.0 was significantly led by people living with HIV sector, reinforcing the JIPA principles with continued technical support from Human Science Research Council and SANAC, and we do appreciate that. The scope of study, while the 2020 index focused on 6 districts across 3 provinces, both the 2014 and 2024 indexes were conducted nationally, covering the same 18 districts to ensure comparable data. The PLHIV, Sure. The aims and objectives of the Stigma Index 2.0 is to document and assess the levels of HIV-related stigma and discrimination experienced by people living with HIV in those 18 districts, so that we can understand these levels of stigma, so that the PLHIV sector, when they want to respond, they are very clear and there's evidence-based regarding it. In terms of informed policy development, is to inform the development and implementation of national policies that protect the rights of people living with HIV. Because in some areas, if you disclose your status, some people, they start to violate your rights or stigmatize you. So we wanted to make sure that we also inform some policies through the findings. Then on guiding programmatic interventions, is to inform programmatic interventions on HIV-related stigma and discrimination. Because through these findings, you are able, as a PLHIV sector, to develop some programs that talks to respond to these findings. The study methodology. In 2024, Stigma Index 2.0 employed rigorous methodology to ensure robust and representative data collection, focusing on diverse demographics and community engagements. So in terms of the sampling, we went to the same districts, which is those 18 districts that we implemented in 2014. Then on stigma index sample size, we use a calculator to estimate the minimum sample size required in South Africa, supported by Human Science Research Council, including the global network of people living with HIV. It was in between where we used to consult with them. Then in terms of the eligibility, participants were required to be 15 years and older and have known their HIV status for at least a period of the last 12 months. As South Africa, unlike other countries, we have made a request that we want this study to also reflect the age group starting from 15 years. As we all know that in the country, we have those who were born with HIV. And those adolescents, they have different needs. And they are also experiencing issues related to stigma and discrimination. So it was important as a country to make sure that we also touch on this one. Then in terms of the recruitment, we used a combination of venue-based and limited chain referral sampling. We also use data collection that was primarily collected in healthcare facilities in partnership with PLHIV Sector and community-based organization, using the support groups, adherence clubs, and working with our healthcare facilities as well. On sectoral inclusion, LGBTQ plus was part of this study. People with disability participated in this study. The sex workers as well participated in this study. These sectors are from SANAC, including PLHIV was part of the study. Key findings. I think on this study, we want to demonstrate in terms of provinces that participated and districts that participated. As you can see, KZN is one of the provinces that had a high number of people participated in this study with 639, as compared with the Eastern Cape that has 506 people who participated. And these people that are 18 years and older. Then when you go to districts, you can see Vembe 334 who participated. Vembe is in Limpopo provinces, as compared with Waterberg in the same province with a number of 197. In terms of profile of participant by sex, age, by sex and age, key populations and non-key population. You can see there, females are higher, as usual. We all understand in issues related to your response. Males, they always come back. Then you can see that we have 63.6% females are leading. Then when we go to the age group, you can see that between the age group of 25 and 49 years, it's high, it's 69.7. Then when you go to key population, you can see sex workers as compared to transgender are high with 14%. Then those we regard as non-key population, it's 71.5%, of which is high. Then when you profile, go to profile of participants in terms of demographics, you look at the age, gender identity, and location. You can see those who participate in terms of location is 55% in urban and 45% in rural areas. Then when you go for education and unemployment, you can see on education, those at secondary level are high with 58.7%, and those on employment, you can see that it's those are unemployment is high. Yeah, it's high more than those that are full time. It says we still have a problem in South Africa that we need to address. That relates to unemployment, especially on people living with HIV. When we go to treatment and support for diagnosis, it's at 67% for people that had been living with the HIV for more than 5 years. Only treatment, those that are on treatment, it's 97.6% that are currently or ever on ART. On support networks, it's 38%. Those that are part of PLHIV support groups. When you go for membership to a support group by sex, age, key population, and non-key population, you can see there the overall is at 38%, while when we look at gender, you can see females are higher than males with 39.8%. Then on age group, you can see that 50 plus, we have people living with HIV that are aging with HIV are at 40.9%. Then when you go on key population, you can see that both MSMs and transgender are high. Then those who regard themselves as non-key population are at 36%. Then when we go to household dynamics and basic needs of people living with HIV in South Africa, you can see that 18.7% care for no children, while we have 43.2. Thank you. While we have 43.2% on care for 1 to 2 children. Then 27.7 is care for 3 to 4 children. Then 10.5% care for 5 plus children. These figures highlights the significant caregiving responsibilities and varying degrees of economic stability amongst people living with HIV households, demonstrating the need to targeted support interventions. You see on this side where we talk about meeting basic needs. Those who are struggling most of time is 12.3%. Those struggled some of time is 40.4%. Those never struggled in the past, it's 47.4%. Then the complexities of sharing HIV status. When we look at on this slide, where people living with HIV are sharing their status, you can see in this slide that they prefer to disclose to their family members. And I think it's because there's that feeling that our family members will be the first one to support us, to give that courage, so that we can accept the HIV status and be able to live with it, as compared with friends, husband, partners, children, neighbors, at work, in local leaders, even at school and in churches. So they prefer to disclose their status to their family members so that they can get the necessary support. In terms of experiences of disclosing HIV status on positive disclosure, we can see on this slide that 65.5 participants experience positive reaction when they disclose to close contacts. As I said, that they prefer to disclose to their family members. Then in return, they get a positive response. However, they dropped significantly to 40.8% when disclosing to less familiar people. Then unintended disclosure is small but critical. It's 3.3% of participants reported their status was disclosed without their consent. And we, as people living with HIV, we don't even need this 3.3%. We need a stigma-free society in our country. Then in terms of the externalized stigma and discrimination, the weight of societal judgment. As much as we appreciate that there's decline in terms of the external stigma, but as people living with HIV, we are not happy. It says there's still a lot of interventions that we need to do in our community because we don't need that. I think, as I said, that I have the core chairperson, the core facilitator, who's going to assist me in presenting here. Comrade Tangena, will invite him as a co-principal investigator to take a lead on this one. Then I'll come back later on recommendations. Thanks.
Thank you very much, comrades. One of the things that came from the findings is that people who are living with HIV still continue to carry the burden of guilt, of shame for living with HIV. And we have seen this on the findings that 48.6% of our total sample have reported having a difficulty telling people of their HIV status. 26.7% said they are hiding their status from others, while 17.3% feels guilty for being HIV positive. And we can see there that there's also those who have reported feeling ashamed and sometimes feeling worthless for being HIV positive. Now, let us look at the breakdown of those who have reported to be experiencing internal stigma. We see that 54.6% have experienced the feeling of shame or guilt at some point in their lives, and a large number of 57.3% is mostly men, with young people or youth between the ages of 18 to 24 being the largest group that has reported experiencing stigma, internalized stigma. In terms of key population, we see that internal stigma affects people who are using drugs, followed by transgender individuals and MSM. Our participants have reported having to avoid social gatherings on the basis of their HIV positive stigma. We see here 6.4% said they have chosen not to attend social gatherings. 5.5 have decided not to have sex. So this means that stigma does affect people's rights in terms of sexual and reproductive health. This is the impact of avoidance by age, sex, key population, and non-key population belonging. And here we see that, again, people who are using drugs and sex workers continue to be largely affected. Now let us look at the stigma in the healthcare settings. We see there, even though the numbers are relatively smaller, but with South Africa having made so much progress in terms of our response, we should not be having these kind of cases. We see that 3.2% of our participants said that they have been advised at some point not to have sex because of their HIV status. 3.1 reported being talked badly about or being gossiped about because of living with HIV. 2% have reported verbal abuse, whether it's name calling, yelling, scolding, or being otherwise verbally abused. 2% have been denied health services, and which actually needs focus. 1.9% their status has been disclosed without their consent, while 0.9% said they have been physically abused, and 7% avoided being advised or to take extra precaution because of their HIV status. Now again, let's look at these experiences of one of more forms of stigma and discrimination from healthcare workers. We see that female or women that makes 3,194 have experienced stigma in healthcare settings. We see there that the two age groups that are mostly affected are young people between the ages of 24 and those who are 50 plus, with a total of 331 having experienced stigma in the healthcare settings. In terms of key populations, sex workers continue to be part of the group that is affected, with 699 people, followed by people who are using drugs, MSM, and transgender. Now, we have also had participants who have reported being coerced not to have children, and who have experienced discrimination. We see there that 2.1 in the red box have reported being pressured to take ART during pregnancy. We do understand that ART is a cornerstone in terms of HIV management, but it should come with information, and no one should be forced to take treatment if they're not ready. 1.5% pressured to use a particular infant feeding practice. 1.2 have reported being pressured to use particular method of giving birth or delivery options. And these are reporting, they're concerning cases. Again, understanding where South Africa is with our response. We see the 1.1% have been advised not to have children, so their right to have to childbirth has been taken away from them. 0.6% pressured to be sterilized. It might look like a small number, but it's very concerning, and it's something that we need to pay attention to. 0.4% have been sterilized without consent, while 1.3% told to use specific contraception to receive treatment. Now let us talk about intersecting stigma. These are experienced by key populations. It could be stigma on the basis of HIV status, gender expression, gender identity, and many other intersection issues. Now, if we look at this slide, we see that 23% have felt excluded from family activities, and that is bisexual. People who are using drugs, 504 of them. People who have, and we also see that people who are using drugs are also leading in terms of having felt a family made discriminatory remarks or gossiped about them, being followed by sex workers, as well as bisexual and lesbian women. We also see people who are using drugs again, saying that they have at some point avoided healthcare services because they've been concerned about their privacy or their confidentiality not being respected. It's followed by lesbian women, sex workers, bisexual men, and then transgender and MSM. There are participants who have reported being blackmailed, and here we see that lesbian women were mostly affected, followed by sex workers, people who are using drugs, bisexual, transgender, and lesbian. Key populations have also reported physical harassment or being hurt on their basis of either their sexual or gender identity. And here, those who are mostly affected are people who are using drugs, with 12.9%, followed by lesbian women, sex workers, MSM, transgender, and so forth. People who are living with HIV, with disabilities, people living with HIV who are also disabled, have experienced being multi-levels of stigma on the basis of their HIV status and also being disabled. As you can see there, that a percentage of about 23% have reported that their family has either made discriminatory remarks or gossiped about them. 19% said that they felt excluded from family activities. 12.8% have been verbally harassed. 12% felt afraid to even go to seek medical attention. 8.7% avoided health services because of privacy concerns. 5% someone has ever they have at some point been blackmailed, while 3.9 and 3.3% have reported physical harassment and having been approached for sex to cure HIV respectively. Now, these are the experiences, these intersecting stigma reports disaggregated by disability status, age, key populations, and non-key populations. And I think what is important to highlight is to see that key populations continue to experience intersecting or compounded levels of stigma. In our survey, we included South Africa-specific questions. We wanted to understand how does living with HIV as well as TB affects our participants, and we can see that close to 38% said they've been gossiped about. 23.5 have been teased or insulted or sworn at for living with HIV and TB, and 23.1% they have reported feeling unclean or dirty because of their TB diagnosis. I'm going to hand over to Comrade Mluleki, but before I finish, I'd like to acknowledge all 5,000 plus voices of people living with HIV, data collectors, and HSRC, SANAC, the Global Fund, for the support. Thank you.
Thanks, Comrade Duncan. Then in terms of the recommendations on disclosure support, we recommend that the National Department of Health and Provincial Department of Health should implement a partner and social network referral programs for HIV testing. On PLHIV-led workshops, we recommend that people living with HIV networks should design and lead community workshops promoting voluntary disclosure and emphasizing confidentiality and empowerment, particularly for women and key populations. Then on healthcare worker training, we recommend that the national and provincial Department of Health should ensure comprehensive training for community healthcare workers to provide empathic, supportive disclosure services. On multi-sectoral collaborations for disclosure support, we recommend that the Department of Health should lead implementation of disclosure guidelines and healthcare workers training. On the Department of Social Development, we recommend that they must provide resources for counseling and support groups. On Department of Women, Youth and Persons with Disabilities, we recommend that they must ensure gender-sensitive approaches to disclosure. Then on civil society, we recommend that civil society must implement peer-led support and awareness programs. So HIV, it must not be seen as the responsibility of people living with HIV only. It cuts across. So all of us must take ownership to fight stigma through collaborations efforts. On community-led education, we recommend that people living with HIV networks should lead collaborations with CPOs, NGOs, traditional leaders, and youth groups to strengthen education and support mechanisms. Then on anti-stigma campaigns, we recommend that we need to implement evidence-based cultural sensitivity awareness programs and campaigns to eliminate HIV-related stigma. I think this study will also help us to do those campaigns. Then on policy development, we recommend to develop inclusive gender-sensitive policies to prevent and address stigma in the healthcare settings and at community level. Then on multi-sectoral approach, my eyes. On multi-sectoral approach, we recommend collaboration across departments with the PLHIV sector to develop integrated right-based interventions that protect people living with HIV dignity and promote non-discriminatory services. The HIV and AIDS must not be seen as a responsibility of Department of Health and Social Development. We are calling upon all the departments to be involved. On combating internal stigma, which is self-stigma, that is rising amongst people living with HIV. We recommend peer-led campaigns. PLHIV networks should develop evidence-informed advocacy, peer-led campaigns to address internalized stigma and promote mental health awareness. On positive messages, we recommend that the Department of Health, SANAC, PLHIV networks should design national awareness campaigns addressing psychological distress, low self-esteem, and reluctance to seek care. On U is equal to U, we need to strengthen undetectable is equal to untransmittable messages through healthcare providers, schools, and media with cultural appropriate communication. I think on this slide, we are reminding ourselves that when we launched EU is equal to you a campaign, we have just launched it. We never implemented it. So PLHIV sector must make it sure that we work very close with those partners to implement it and make it sure that we design positive messages in addressing stigma. We must include those departments, PLHIV sector. Then on peer-led campaigns, let's make it sure that we take a lead on that one, and we need to make it sure that we work with women living with HIV. Fortunately, within we do have a positive women's network that can take a lead on that one. Improving healthcare facilities. We recommend a capacity building to increase healthcare workers' capacity through trainings on intersectional stigma, patient rights, and gender-responsive care, with PLHIV as co-facilitators. Because our experiences as people living with HIV and key population at a healthcare facility level, it's a problem. It's a problem. Hence, we are recommending a capacity building so that together we can work in addressing these matters. On cultural sensitivity training, we need to deliver community-informed training modules, prioritizing women, adolescent girls, sex workers, people who use drugs, and LGBTQ+ individuals. There are monitoring systems. We need to establish independent, confidential systems to identify stigma and rights violations with clear, compliant procedures and resolution mechanisms. Then on people-centered approach, we recommend institutionalized approaches, prioritizing dignity, preference, and holistic well-being of people living with HIV through respectful care protocols and inclusive facility design. On human rights and access to justice, on resource mobilization, the Department of Health and donors should mobilize resources for people living with HIV networks to implement stigma reduction programs and tracking resources flow and outcomes. You see, now that we have given a go-ahead as people living with HIV to practice IGPA principle to take a lead to conduct this study. But when we are launching these results, and we'll be disseminating it, there are people that are outside there that will take the same results, design nice programs and responding to this, instead of allowing people living with HIV to take a lead in responding to this. But how going to do that if we don't have resources? Hence, we are calling for departments and donors to invest in programs that seeks to respond to these findings. On rights to education, people living with HIV networks led by women living with HIV should provide education on rights, policies, and regulations for women across all age groups and key population. We do have you, PWN. We will support you. Then on anti-discrimination campaigns, government and people living with HIV networks should increase awareness and promote campaigns addressing stigma, monitored through regular assessment of public attitudes. Then on legal support, we recommend that the Department of Justice, Illegal Aid, and PLHIV networks should collaborate to support access to justice, include legal assistance and advocacy services. We must make use of that department, comrades. We must work very close with them. For a long time, we've been ignoring it. Then key takeaways. Community leadership. We want people living with HIV networks, especially women-led organizations, must be at the forefront of designing and implementing all initiatives. Stand. On multi-sectoral collaboration, effective responses required coordination across health, social development, justice, education, and other sectors as well. On right-based approaches. All interventions must prioritize dignity, confidentiality, and non-discriminatory, aligned with national and international frameworks. We need to use them. On robust M&E, we need a comprehensive monitoring systems that are essential to track progress, ensure accountability, and guide continuous improvements. Partners that participated in this journey, who supported PLHIV sector, we want to thank Global Network for providing guidance to people living with HIV networks in South Africa, and supporting us in advocating for ICHIPA principle to take a lead to implement this study. We also want to thank all the organizations of the SANAC PLHIV sector for trusting NAPWA to take a lead in coordinating and managing this project for Stigma Index 2.0. To ETAC, which is Treatment Action Campaign, Sanarela, a Positive Women's Network, a Positive Action Campaign, and NAPWA. We thank you. On the Human Science Research Council, thank for always raising your hand every time we conduct a stigma index. And I'm aware that this process, it was a process of providing the capacity building to us. Now we can proudly say we have people within the PLHIV sector that can be principal investigators. We have people in our communities that are able to be data collectors. Without them, will not have be appreciating, celebrating that we have at this study. But because of them, we are here. And those supervisors and those provincial managers, I think they are here. O Comrade Temba and Comrade Godfrey. Then on funding sources, we want to express our appreciation to Global Fund for making resources available for the PLHIV sector to take a lead in such a study. As much as it was not an adequate funding, and we struggled even to launch this report, we took time, but we appreciated it. We appreciate that, and we believe even in this GC7, there will be something for people living with HIV sector that is set aside to continue with research on this. We want to also send our appreciation again to the principal recipient on GC6, that was AIDS Foundation of South Africa, and the sub-recipient, that was South African National AIDS Council, for trusting the PLHIV sector with your resources. We appreciate that. We know in between there were some issues, but at the end of the day, find a common sense and continue working. Hence, we have this study. We say thank you. Yeah. Thank you, colleagues, for supporting us. There are comrades that we have lost in South Africa through HIV stigma and discrimination and hatred. Anyway, especially those that are belonging to LGBTIQ+, including sex workers. We have lost comrades like Comrade Jason Vesenar, who was once a champion of stigma. The first one that was launched in 2008, Comrade Jason Vesenar was taking lead. He was brutally murdered because of his sexual orientation and HIV status. So studies like this, they also remind us, Comrade Ngosi Johnson, who took a lead to fight stigma, being open, making sure that there's no other child who will be born with the HIV in this country. We dedicated the study with comrades like those comrades. Can we please all stand up and have a moment of silence in respect of those comrades? May their souls may rest in peace. Amandla. Phansi ngestigma se-HIV and AIDS phansi. Qina mntu ophila ne-HIV and AIDS uzanqoba qina. Amandla. We may be seated. Thank you so much.
Siyabonga Comrade Mlu no Comrade Duncan with that report and honoring those we lost due to stigma and discrimination. And I think as we've seen the report, we are still facing the very same stigma. Just to share a short story, not a story, because the story is overseen, but what happened to yesterday, I received a call from one of my neighbors who had a sister who had a child living with HIV. The child is using drugs and she has 5 children. 2 of those children are born with HIV. And the gogo, when she takes the 3-year-old one, actually the 2 young ones, it's 3-year-old one and the 5 months old. When she's taking the 3-year-old one to the facility, she's been given attitude. She's been chased away at Dr. Musa. She's been told that the mother needs to come. And we know how people are using drugs are. Sometimes they are available, sometimes they are not available. So the child is not receiving proper treatment because the healthcare worker doesn't want to give Gogo medication. And she's going back to the facility tomorrow. And she was telling me that she's scared because she doesn't know what kind of attitude she will get. So what I'm trying to say, the issue of stigma, we are seeing it, it's still happening. And if we are a caregiver and we are struggling like that, then it's a problem. And to the extent of that, even the 5-year-old, the mother keep on running away with the 5-year-old. I advise her to go to social development so that she can get help and get that child back home. But you can imagine that the stigma goes a long way, not just to people living with HIV, but even those who are supporting us as people living with HIV and those who are taking care of the children who are living with HIV. They are still facing that stigma and being made to feel like what you are doing is wrong while the grandmother is taking care of the grandchild and making sure that the grandchild is living a healthy life. So the issues on the ground are still very serious. And even the daughter, she's no longer taking treatment. And she's scared to go to the facility because she's been once chased to say, "Ungulile, you're dirty. You're going to take these ARVs and sell them." So this is a reality of stigma that we are facing in healthcare settings. So without wasting more time, I think we are doing very well on time. I want to thank the presenters and the speakers here. You've done very well, very well. You kept us on time and we are moving in the right speed. The person I'm about to call Upumile. So because Comrade Temba ngatu Upumile, can I call Godfrey? Just to give us, Comrade Godfrey, how was it to work on this study? What are the key issues that you identified as the person who was supporting the province? And what is your take as a person living with HIV and leading people living with HIV on these results of the stigma index? Just 5 minutes, uziphathe kahle. Because, wow.
Yo. I don't know what to say. Good morning. Happy. I want to say, you know, it has been a good experience working in this project and in the study, because of I would say it was for the first time working as studies as but the experience that we got from the beginning, you know, when we started with the piloting of the project, I don't want to say it was hectic because of we had technical glitches, we had everything, you know, that you didn't that you think of. However, we managed on that, you know, like on the pilot, and then got to make sure with the help of the HSRC staff, especially the technical team, you know, that was working on the red cap and everything, to make sure that we get the right data. Not, you know, no, we do not get a data wrong, because of if like we get the data wrong, we wouldn't be getting such results. We'd be getting, I don't know, we'll be giving, or we'll be feeding the community lies. So we did not want to give community lies, and we're traveling to, you know, to communities that we were working with. I would say it was also difficult. Comrade Temba and I, we were traveling, you know, far most different provinces, and then, you know, giving support to the supervisors that we were working with. Ever beautiful people that we were working with, I would say, especially supervisors, you know, even though, you know, but you manage as a manager to say, how can we, you know, sync together and then make sure that everything that we're going to give out, it's proper and forever beautiful to also, and so that the departments also, you know, like, let me put it in this way, working also with Department of Health, it was difficult, really difficult, especially managers. Yeah, ne? I don't want to tell you lies. However, you know, when you are given that, you would, like, you can be able to speak to people, you know, you bring them and, you know, align them with the program, so that you give them like, this is not the program that will take personal information and give to people, because we're trying to protect the people that we are talking to, and also protecting the data, so that it can only be shared to the department and relevant departments also, so that we can work together in making sure that advocacy also should come through. And, you know, for now, I want to say thank you very much, Comrade Blue, Comrade Shabalala, and other comrades, Comrade Dr. Lelo, Comrade Dr. Sean, Comrade Dr. You know, also, like, when we did the policy review, it's where we learned, and this, you know, transfer of skills, to say, when you do this, you learn. And I've learned a lot. Data collection, data cleaning, you know, it's something that I never knew before, even though, you know, you do research and in your studies and whatever. But that one was it was a wow, especially data analysis, and it made me sure, like, hey, data analysis straight, and I should be a true researcher. Yeah. So I believe Comrade Temba also, like, share the same sentiments. And thank you very much, comrades, and thank you very much for having faith in us, and we did it. Thank you.
Thank you, Comrade Godfrey. Now we know that in the near future, Dr. Mpumi, we oversee. We don't get involved, but we just oversee. And we really thank you for what you are doing for us as communities. And you must know that the knowledge and the skills that you are transferring are very critical to us as communities. And it will not only end with people living with HIV. We believe also other sectors, they will get this such knowledge and skills. We are talking about people who are using drugs. We really need them to understand what is really happening, because we understand that people who are using drugs are not just taking them because they like them, but there are issues behind that make them to take drugs. That is why we shouldn't discriminate. People who are use sex workers, there are issues that they are dealing with, which they make them to decide that I want to be a sex worker, or I want to do this job. So they need to be respected as much. And also women, we've seen that as much as we are, women are the people who are seeking help most, but we are most discriminated also. So, bafazi khanyisa, I mean ngizonikhomba kunzima asebenzeni siyazi ukuthi kunzima, the funding it's not there, but people need us, so we need to work together. I think UNAIDS is online. I'm not sure whether they are, but I have just few questions if there's a representative of UNAIDS online. Looking at this report and seeing that we still have such challenges, and with the role that UNAIDS have played over the years in combating HIV, now we are sitting here, we are not sure from the UN level what will happen to us as people living with HIV, because UNAIDS is closing its shop. We are talking about the sunset clause, and we are trying by all means to communicate and to share our voices, to say we really need this office. But it seems like we are not getting an attention. The decision has been made. So what do you think will be how are we going to be taken care of as people living with HIV? And at the UN family, which office will be catered for, so that we can always get these reports that we are getting and setting these targets that we've been setting, especially now that key populations are the ones that are mostly affected. I'm not sure whether we do have a person from the UNAIDS. I know we have the social development, but while we are still looking for the person from the social development, let me come to you, my brother, from the social development. I think from this report, you have seen that there are a lot of issues of stigma related to families, and also because of people can't meet the basic needs in their families. What will be the role, or what is the role of the Department of Social and Development it's playing, and how best can we work together to collaborate these two departments, especially Department of Health and Department of Social Development? Because I think our principal all the time, they are acknowledging that the two departments they are crucial and they need to work together. But when it comes to implementation, we see a lot of disconnect in terms of addressing the issues of people living with HIV on the ground and with the Department of Health. May I call you on the stage, leader, or you want to address there? You can come here. And also, when there's something that you want to add from your response, you can add. You're welcome to do so.
Thank you, Program Director. Greeting to all the colleagues in the room, and then colleagues online. Protocol observed both online and in the room. Yes, I'm Chris van Rooyen from the National Department of Social Development, working in the Chief Directorate HIV and AIDS. Chabalala, thanks for the questions. People normally say you don't thanks for questions, but I do it. Then let me start with welcoming the findings and the report. I think our thinking at this point in social development is then to welcome the report as a whole. I saw there was only 2-3 recommendations for social development. However, we will rather welcome it as a whole, looking at all the areas like your multi-sectoral approach, specifically. Then coming to your question around the issue of the families, and take into account the role of social development, in particular around the issue of poverty alleviation. I think that's one of the key roles of social development. In particular, that we know that as a department, we are responsible for social protection and in particular the grants in South Africa. Now, we have started a process in the department where we've also then started to review some of the social grant policies or social protection policies. And then we've also started a process where we've zoomed into HIV and TB, in particular to say what are the catastrophic costs and how do we as a department respond to those catastrophic costs. We are working very closely with the TB unit in the Department of Health. We've been supported by the TB unit and then WHO in that space. Now, for us as department, the families are the heartbeat of our communities. That is where we start. And that is our point of entry. And we provide quite a number of interventions. And one of the interventions which we could highlight, in particular for people living with HIV, it's our food nutritional program, our community nutritional center, CNDCs, which then we've actually responded to provide basic food needs to families, in particular in rural areas where we have a high level, and even urban areas, we have high level of hunger. So that in itself. Now, coming to your question around the multi-sectorial approach with the Department of Health. Now, we've are quite active in the SANAC structures from the national. However, we are also active in our provincial structures, provincial AIDS councils, where we encourage our colleagues then to play active roles, particularly around the social and structural barriers of HIV and AIDS. And we identify stigma as one of them. Stigma is the #1 killer for people living with HIV and TB in this country. And we respond to that by saying that let's allow the mechanisms of our provincial AIDS council, our district AIDS councils, and support people living with HIV. However, we also have bilateral with Department of Health, where we've also tried to find synergy around our strategic planning, in particular around HIV and TB. And that is an ongoing process that we've started. But I think what I want to highlight is the 2 findings which were quite significant in today's study. The one finding talks about the resource mobilization. It actually tasks social development to say you need to provide resources for counseling. However, I also need to highlight that, yes, we acknowledge that request, and we've started a process where we started to train our social service practitioners, which are social workers, which are social auxiliary workers, which are child and youth care workers, and community-based workers. We've started to train those cadres, particular on the human rights aspects. What we recognize is your findings today around the healthcare workers will be similar to some of the findings to our social service practitioners. I think what we want to advocate in this platform to say, let's not limit the capacity building to health workers, community health workers. Let's also expand that because we need to have a multi-sectoral approach, and we cannot leave our social service practitioners behind because our mothers, our fathers are entering our service offices. And I think the next finding is around support groups. The issue of support groups is very close to social development. We are now embarking on a process where we revitalizing the home and community-based care program from a national and provincial and local perspective. But one of the key activities is to drive the issue of support groups, particularly the focus on people living with TB and people living with HIV. And we hope that looking at that process, it will reignite the support groups. I think the last one is around people who use drug or the PLHIV. Remember that space is also a space of the social development. It's a And I don't want to claim this, but I think we share accountability and we share responsibility to respond to communities. But for us, that's also a key area. Hence, we're having the drug master plan and we're having the implementation plan from the Central Drug Authority in South Africa. Lastly, I think I won't do justice to the 16 days of activism. We all know that we are in that space for the last 16 days and we're closing as a department. However, we want to also encourage to say that as a department, as a collective, as a community living with HIV and TB, we want also to highlight the 16 days of activism, specifically for the protection of children and women. I thank you.
Thank you very much, comrade. And I think you are raising so much important issues, especially when you talk about the 16 days. I think Okanyisa and us, we've been saying it shouldn't be just 16 days. It should be 365 days because every day. And you know, it's so surprising that all these issues of gender-based violence that are happening are only highlighted on the Women's Month and 16 days. But throughout the year, there is less reports on that, while it's happening each and every 3 seconds of our lives. It's happening. You know, as we are touching that, yesterday one of my comrades in my branches, we woke up, she's been brutally murdered and raped and just left there. We don't know the perpetrator. We don't know who killed her. We are talking about a person living with HIV, a young person living with HIV, how she has been killed. So with what you just said, we are taking that, and I think the leadership of people living with HIV also will take your contacts so that we keep in touch and we work together. So I'm told that the person from UNAIDS was on the Zoom, but is no longer there. Aibo. Oh, Tabitha Ukon. Okay, I think she's coming in. While she's coming in, I'm not sure whether she will respond on behalf of the UNAIDS. But because I just see that she's been just admitted, there's Ukeri Danawe. I'm not sure whether he or she. Yeah, I'm not sure whether he or she. I don't want to misgender the person. The person represents Stigma Index International TA coordinator, not from the GNP+. So, Kerry, I just want to know, since you're working on the field of Stigma Index internationally, when you are looking at this data and looking at what is happening in South Africa, what is the experience or how do you compare this data with what is happening internationally, and where can we do better as South Africans, and what interventions that you think we should do to address the issue of stigma and stigma mostly? Yes, thank you.
Very much. Am I audible? Can you hear me well in the room?
Yes, we can hear you very well.
Perfect. Thank you. Well, good afternoon, everyone, and good morning on this side. Thank you for inviting us to be part of this important movement. My name is Karen, and I work at ICW. And ICW is the founding father, one of the founding partners of the Stigma Index. And my role right now is to coordinate the technical assistance program on behalf of the Stigma Index International Partnership. And it's a pleasure actually to join you today, even remotely. First of all, just a huge congratulations to the entire South Africa's team. This has been one of the biggest implementation of the Stigma Index 2.0 anywhere in the world, with the largest sample size that we've seen since we updated the tool in 2018 and the new methodology in 2020. And that's something to be absolutely very proud of, because it also reflects like the scale of work and the level of commitment shown by everyone and by the communities, from the country coordinator team to all the networks of PLHIV, to the steering committees, to the academia, to the research partners, interviewers, supervisors, partners, funders. And from the partnership side, it has truly been an honor working with the South African communities, organizations, academia, and partnership. We know how much the dedication it takes to run a study of this size, because you also have to get like security, ethics approval, managing logistics in multiple districts in a country as big as South Africa, making sure like interviewers are trained and supported, handling the data cleaning and verification, and staying on top of deadline, because I remember one of the most pressing things when we were doing the TA was the deadlines. But on top of all that, we also saw a team that go an extra mile, that had intersectional approach in mind, that included key populations, that included young people as well, and have the human approach of this is a research, but also we are presenting the real stories and experiences of people living with HIV. And that's why we also want to recognize the leadership. The Stigma Index has always been designed as a study by people living with HIV, for people living with HIV, and not just about us. And today we have heard and seen like the real stories, the reality of the stigma in all its forms, from internalized stigma, discrimination in healthcare, barriers to employment, disclosure challenge, and very happy also to hear from other panelists about the social and structural issues that have been identified with the Stigma Index. Because the heart of the Stigma Index, even though it's highly quantitative, the heart of the Stigma Index is advocacy. And to answer your question, the Stigma Index is one of the most powerful tools that many communities have. You can do evidence-based advocacy. We gather information not only on healthcare settings, but we also gather information around family and friends, society, and internalized stigma. And through the entire process, we also increase the leadership of the community on data collection. We also increase the the leadership on taking ownership of the data, because I've someone said at the beginning of the launch, the data belongs to us, to people living with HIV, and the data for South Africa belongs to people living with HIV from South Africa. And looking ahead, we are excited about how this data will be used. Please know that the international partnership and all the partners are here to support in any way we can. It can be used for advocacy, for planning, for improving services. I know we have a very tough and complex year as HIV response. But the Stigma Index, one of the powerful tools that we can use to fundraising, to change, to monitor, and to continue to do data collection on what is actually happening in the real life of people living with HIV. Because it also brings a visibility to what the communities have been saying for years, and trying to turn the realities into data and turn that data into action. And those actions cannot be ignored. And this is also why we are very committed to continue this work. We are very happy and glad to support right now other countries across the African region as they launch their implementations. Some of them are preparing their protocols right now. Some of them we are actually, again, struggling with the timelines and deadlines, and we're finding ways to implement in the best way possible with the standardized methodology. And the leadership coming from the region has been actually very inspiring, and looking forward to working with the community alongside the next phases in the new HIV response. And yeah, on behalf of the partnership, just thank you again. It has been a pleasure working with the South Africa team. Again, this is the biggest implementation we have so far since the launch of the Stigma Index thing in 2005. Thank you for your leadership, for your patience, your collaboration, and the trust in us and our TA delivery as TA providers to actually roll out implementation. And also thank you to the Global Fund for supporting this work. We stand steady to continue the work alongside you and as you take this data forward. And congratulations once again, and wishing you a successful launch. Thank you.
Thank you very much, Kerry. Thank you very much. Tabitha, I hope she's still in the room. Comrade Tabitha, the questions are already asked, but I'm going to ask them for you. The question is, looking at this data that is being presented here, showing that as countries, we still need the support of UNAIDS and I believe that you have data from other countries on the issues of stigma and what is really happening on the ground. With the issue of sunset clause, from the UNAIDS, and I think you know very well, you've been working with us for years, addressing the issues of people living with HIV on the ground, supporting us as communities, and I'm happy that you are here because I'm talking to the person who understands our issues that we're engaging with now and again. What will happen now that UNAIDS is closing down, and which office that will cater for us as people living with HIV? How are we going to get these reports that we've been getting from the UNAIDS? And because they were assisting us, also us as communities, to advance our advocacy, and assisting also the departments and the government to address the issues that that are affecting people on the ground. So with the closure, what does it mean for us as people living with HIV, and what is your take based on the report? We've seen that key populations are mostly affected by stigma, women, and with all that is happening, I think you know better. Where are we dumped at as people living with HIV? Over to you, Tabitha.
And I think for me, listening into every speaker and actually going through the entire presentation, I think first, Sibongile, we just need to appreciate that we have achieved one very important objective of this work, which was to document the stigma levels. That's why we are having this conversation. So congratulations on this huge achievement, because it's been done. South Africa now has a documented outcome on the Stigma Index 2.0. So that for me and everybody else is something to be celebrated. Thank you so much for this achievement, colleagues. Everybody that put in their hard work to ensure that this work was done and completed with so much dignity and so much integrity. Really, really appreciate it. So we achieved that. Before I answer, if I'm even able to answer your question, because it's a very difficult question, very, very difficult. And I think the other achievement of this work has been to, at this point, at conversation, to say, we can safely say, also looking into what the other work that we have been doing as a collective, we've been able to provide guidance on programmatic interventions through this work. So you really have met that objective as well, and thank you for that. I think the biggest work that now sits with all of us to grapple with is to inform policy development, which was another objective of this important work. And looking beyond this, you know, Sibongile, you and me come from an era where I know that was a long time ago, where we really pushed and did this work without resources. We come from that era. And I think what I am trying to bring from that era is to remind us all, because this is not new information, and to remember the skills and the capabilities and the wisdom that existed and continued to exist and carry us in the AIDS response, that has ensured that work beyond a price tag has continued. Because this work is priceless. We cannot put an amount to this work. The magnitude of this work requires all of us coming together and doing what needs to be done over and beyond the little amount of resources that are readily available to help us do this work. We appreciate the resources, we will always do, and we need them moving forward. But because we are now at a place we've never been, we have never been here in the AIDS response. We are caught between a hard place and a rock, and this rock is too big, and this hard place is really hard. So we really have to now look at how do we maximize on the current agendas, Sibongile? How do we maximize the agenda on breaking down barriers? Which pieces of that agenda can we take advantage of and ride on its wave to ensure that this work is first reaches people on the ground. This information for me and everybody else, I'm sure, the biggest question we have right now is how do we ensure that people on the ground reach this information? Because the privileged people online and the privileged people sitting in the room already have access and we have received this information. But we serve a bigger constituency than us online and us in the room. So how do we then ensure collectively that this information cascades down to the people with whom we conducted this research, the participants? How do we ensure that the constituents of people living with HIV reaches this information and this data? And number two, how do we assist them programmatically plan with this data at hand? Because we are simply a handful in the room and online. So I have more questions or more challenges for us all than really answers. And this is work that has to happen. Whether UNAIDS is sunset and does not exist as a country office in South Africa, this work has to continue. It's going to take us all our efforts as activists and politicians and in academia and people with lived experience on how do we come together and find the best way forward with this work. So how do we theme messages and findings? How do we simplify this data to ensure that also it is simply understood? Because we appreciate science when it's simplified. And thank you, HSRC and colleagues that were engaged with this work for simplifying science here, even with the speakers. I could sit here and engage with every slide because you simplified science. How do we then simplify it some more to reach our younger population, to reach young people living with HIV and young people in general, in all their diversity? Because this is work that has, I'm sorry, I know I'm speaking to work that must still continue because that is our fact, that is our reality. This work has to go on. And how do we ensure that the findings influence care and support programmatic interventions of people living with HIV? How do we make this work resonate within those programmatic areas precisely? And how do we influence the HIV prevention roadmap agenda with these findings? Because these findings resonate with every item I have mentioned here, which is our big agenda. And also on the human rights agenda, how do we make this work find its own resonance? I do not have an answer in terms of what must happen now that UNAIDS is said to be sunsetting. But I think as a collective, we can come up with interventions and ways and means on how this work continues, because it has got to continue as it should. I remember, Mluleki, when we launched the Stigma Index 1, I might be butchering terminology here, at the International AIDS Conference in 2016. I remember the buzz in the room and the opportunistic moment that was for all of us, because we launched this magnanimous amount of work at an international conference. So we were able to reach thousands of us globally beyond South Africa in one sitting. That was the AIDS conference in 2016. And today, we are not there. We've just had ICASA. And how do we then become opportunistic of another conference, which could take a while? But again, what do we do in the meantime before then to ensure that this work reaches the people it should be reaching? And how do we work together? Because now it seems, as it should naturally, that we must ensure that this work is fit in. I don't like the terminology of streamlining, because sometimes when we streamline things, they get lost in the bigger streamlined agenda. How do we make sure that this work finds its dignified and respectful space in our current agendas. So for me, I have more questions than answers, and I think it can be done, Sibongile. I think let's look beyond what could become of UNAIDS in the near future, and take comfort in that, in knowing that UNAIDS is not the walls of the offices that you would come and have meetings. It's not. It was UNAIDS' greatest talent, it's its human resource, and it's people like myself. And for as long as we have air in our lungs, this work has got to continue. There is no negotiating that. Let's look beyond who do we go with? How do we ensure we hold each other's hands and continue with this work? Because I'm a South African. I am simply an international civil servant by virtue of my employment at UNAIDS. However, I am a South African that also cares about the AIDS agenda in my country. It's always been personal since year 2001, since I worked in this space, since we as a collective kept South Africa company in the AIDS response. So the people that have always kept South Africa company in the AIDS response will continue. We know each other from when we were way very young. We've matured now, and we also understand that the stigma agenda is pervasive. It's like an irritating noise in your ear, but also has impacts that you can see with your own eyes. So I feel that the agenda of stigma also brings all the other important facets or that make up the people that we serve, the people living with HIV as social beings. How do we then address that huge agenda, also focused on serving our constituency with the human resource, with the people that are still here and will continue to be here? Because again, let's also remember that UNAIDS is not a building in New York or in Geneva. UNAIDS is not a building in South Africa or in the ISA region or anywhere across the globe. It is the people. It is us, the people, that serve the people and will continue to serve the people, because for us, this politically is very personal, because we have lived experience on the impact of HIV in our families, with our loved ones, in our communities. So it's not an agenda we can let go, because we are also talking about sunsetting UNAIDS. We don't have that luxury, Mluleki. Not at all, Pulu. Not when we know what stigma can do if left unattended. We know what this important agenda, what negative outcomes can become if it is not integrated into the other big competing agendas that are also complementary to the work that we do. So I think there's a lot of thinking together that must still happen. There's a lot of planning together that must still happen. There's a lot of sacrifice that must still happen, Sibongile, because remember the sacrifices we made in the beginning. We are now at a pivotal moment where we are called to make those sacrifices once again. When we had our very first conversations on what did we call those groups? So support group sessions with people living with HIV, when we had the first generation of ARVs, that was very challenging. We were having those conversations with Oros and peanut butter, and we were working overtime.
Yes.
So we are called again to make those sacrifices. I don't know how they look like today, but we really need to come back to that moment where we make those necessary sacrifices we made back then, so that we can serve the community of people living with HIV. Thank you so much.
Thank you very much, Tabitha. You know, you always, when you speak, you remind us where we come from. You ignite that spirit of activism. You always push us to say we need to do this, we need to work, and we have done this. And thank you for all those probing questions that will make us to think further, to say how do we go on. And all of us here in the room and those who are online, we I think all of us, we are thinking of a way forward as we are here to say from here, where are we going? How are we going to disseminate this information? How are we going to use this data to influence policy and also simplify it more to our communities and also make them understand what does it mean? It's not just a number, but what does it mean when you do this to other person, not only to people living with HIV, but to an individual, to a human being. So the study with people living with HIV, it shows that we are disconnecting as human beings to each other, and we need to treat each other better. So with the last 2 minutes that I have, I'm told that the GNP Plus is on the room. So I would like to just get your reflections on the data that has been shared, and how did you feel as GNP Plus when you were supporting the work that people living with HIV were doing in South Africa, working with HSRC, people living with HIV, and also learning from international communities of people living with HIV. How is it working? It's my comrade Florence Riako Anam. Comrade Florence, please come through.
Good morning, good afternoon. For the who have asked us to join. Sorry, I just came in from ICASA yesterday and still recovering, and I think I can feel my voice is weird. Just to say that for people living with HIV, Stigma Index at GNP Plus, this is an opportunity to formally put together our experiences and capitalize them in a way that decision makers can make sense of what our experiences are, and to use that to be able to lead our advocacy to ensure that there is an enabling environment that ensures equality in service delivery and responsiveness to our service delivery. My colleague from ICW, the International Community of Women living with HIV, was on the forefront of supporting the work with colleagues in South Africa for the Stigma Index, working in a partnership group that constitutes the People Living with HIV Stigma Index 2.0 partnership that has the community networks, researchers, including also UNAIDS. I think for us, this is an opportunity to cascade global positions, working collaboratively with our country counterparts to ensure a standardized approach towards measuring people living with HIV stigma. It's a win because it is standardized, but also accepted and used, this data, by our governments to report into the GAM, for instance, that enables that this report is then cascaded at the global level for global level targets, monitoring, and continued target setting on matters of stigma, gender equality, and enabling laws. I would like to complete my small intervention by saying this. We are in a moment of change. Adaptations are happening significantly for service delivery for all people living with HIV. Now is the time to support continued real-time data collection and responsive mechanism for the changes that will happen, particularly as we adapt services into primary healthcare. The people who are likely to feel this pinch are the people living with HIV who have to come into these changes in the facility, and the service providers who have to adapt, quickly learn, and quickly organize this. These two players must come together, must work together to ensure evidence continues to move and ensure that our real-time experiences serve to quickly support leadership in its adaptation and its plans to ensure service delivery for people living with HIV and for all. Thank you so much, and back to you.
So much, Florence, and really, yes, for people living with HIV and for all. So we will continue to use this data for us to be able to work together. So I think you see me for the last time here. I'm sitting down. My co-moderator, my ex, will come. And finish up this program. I just want to thank you for the insight, for supporting this event. We know that we might seem very little in the room, but online we have more than 100 people joined, which we want to thank you for joining. We know resources are the challenge. It means if everyone was here, this room will be overfull. So you will have to have an overflow area. So it shows how much this stigma index launch, it's been appreciated and how long we've been waiting for it. So from me, Umtaga Shabalala, Lukshala Pansi, and then Ubabu Ujiasi, Umyenga Kuma. Ngeneyen. Exiam.
Thanks so much, Comrades Mo. Actually, we are 130 people attending this important event. So I'm just requesting my camera people, don't use this camera. It shows empty chairs, and yet you see 130 practically. 130 inside here were 30 people plus 2 cameras. Are there any questions, colleagues from the floor? At least 3. Yes, ma'am.
Thank you so much again, NAPWA, for showing us that research can be done by civil society, by people living with HIV specifically. I think it's an honor to witness this. Something that stood out for me, as someone who's also been interested and following the research on stigma, something that stood out for me, and I'd like us to maybe outside this room have a discussion on this, is the fact that disclosure to partners specifically stands at 51%. And how will that, or does that continue to influence our efforts towards you equal you? Because it's like we're working against each other. And how can we make sure that programmatically we pinch that specific partner disclosure in the bud, so that it doesn't mess up our efforts. Thank you.
Thanks so much. Yes, ma'am.
Okay, thanks. Okay, I'm audible. Thank you so much. Mine isn't really a question.
I can't hear you.
You okay? Sorry.
All right, no problem.
Okay, so mine isn't really a question. It's to thank the PLHIV sector for the work that they've done. I think with this work, it shows, I think this is what we speak of in the CSF when you talk about intersectionality. And this is like intersectionality in action. How the data was gathered and so forth. And what really touched me also are 3 points. I think Godfrey spoke to it about the experience that is gained. We try, well, in CSF, we do have a research sector, but it also empowers us as a whole in the CSF when we have our own people able to collect data, get ethics approvals and so forth. So to gain that research knowledge, because it stays within the CSF, so that even we get in-house ability, you know, to conduct various projects. But also now with this one, I know that our sector was represented as well. My question is this one, not question, it's just to ask all of us actually in this room as CSF, is to say there's a concern that was also raised by Comrade Mluleki, to say that now someone will see this research, someone will take it, someone will get truckloads of funding and not prioritize e-participation or involvement in the PLHIV sector. Now that happens, and it also happens among ourselves, colleagues, as the CSF. So I think maybe also ourselves, also looking at the financial constraints that we have, with the partners we had before we don't have, the resources we had before we do not have. I think also in the CSF, if we can recommit ourselves, especially I'm listening to what Tabitha spoke to and Comrade Sibongile, if we as CSF recommit ourselves, because even among ourselves, we are built from organizations, there are the haves and the have-nots. And yet we benefit from a sector like PLHIV that honestly right now is a have-not. So we ought to also have some method, some form of MOU or agreements among ourselves as sectors to say that, because this document is going to work for all of us. I know that for the disability sector and for my own organization, I'm going to use this because we still have access to funding. But now also when implementing the recommendations, we must also endeavor to make sure that we incorporate the PLHIV sector, whether it's through employing them, getting them employed, or leading this work even in our respective organizations. I know that for the disability sector, this is going to help us greatly because it's a beginning. Such data from the disability sector that they always cry for with us now.
Yeah.
You know, so what the PLHIV sector has done for us, and not as a disability sector, now we have a responsibility to make sure that this work, these recommendations are seen to. So yes, maybe the traditional funders we have are now no longer there, but NATI, we know that in our organizations we have funding. So let us champion this to make sure that the recommendations for this are funded and it doesn't gather dust. So all of us as CSF, this is a call for all of us. Thanks, colleagues.
Thank you so much, Sis Connie. Then Kay after.
Thank you so much. I just want to appreciate the report and the work that has been done, this collective work done by PLHIV Sector, SANAC, and the Research Council. Mine is comments to say that it would be great if this report will be presented at civil society forum in provinces, that you take it down to civil society forum in provinces, all the province, and also to the PCAs, the Provincial AIDS Council, and then have a recommendation where we cascade it down to the District AIDS Council and the Local AIDS Council, so that there is that ownership and also implementation of the implementation plan when it is developed. So I would really appreciate that you have a program where you take it through those forums at provincial, district, and local level. Thanks.
Okay, Kay, and then after we go online, get 3 people there.
Okay, thanks, Mfundis. I'd like to thank everyone who was involved in doing this extremely important work. And my comments are really on that slide that I'm really struggling to move past, where, it's showing that most stigma that people experience come from families, and I'm really, really struggling to move beyond that. And it is it made me remember of something that we often talk about how broken are our family structures. And also thinking to what Tabitha was talking to, to say we have been doing this work. Yeah. It is time for us to really acknowledge where we are in terms of limitation of resources. It is time for integration. It is time for us to be strategic. Who else out there is doing work with families? And is there inclusion of HIV, stigma in the work that people are doing? Is there, what interventions can be done at a family level. Because if family yako basically should be your safety net. Your family, it's people that are close to you. So if we are seeing data that actually the rise in the stigma is within the family, so it is really important for us to look at work that is currently being done in the country with families, review that work, and for integration to be pushed at that level. Because half of our problems in most of sectors in society are caused by the fact that our family structures have broken down. And that's where we need to go and fix and have a holistic, approach. Because we can't be having interventions that are competing with one another, especially given that resources, the only reliable resource that we have at the moment, it's human resource. And guys, we are tired also of volunteering. We really need to be innovative.
Thanks so much, Kay. Anyone online? 3 people. You are over 90 people. Unfortunately, you can't all speak. Only 3 people, and I can't see your hands. You can just come in online. Yani Zamel.
There are questions that maybe you can read.
Thank you so much, Prof. Okay. Am I audible?
Yes.
Thank you so much. My name is Peter Matebula from Mpumalanga under Men's Sector. Allow me, Prof, again, just to welcome the report and really appreciate PLHIV Sector and all the partners who have played the role to ensure that such information is gathered and it is shared across. However, I'm looking forward to say in future, we need to ensure that men and boys are involved in such what you call participation when it comes to research, because it did reflected that there is a minimal participation of men and boys in such what you call activities. So we need to ensure that they are also brought into the space and ensure that also through the Betterment for Tomorrow campaign, bring enough men to participate going forward. Thank you so much, Prof.
Thanks so much. Second person online.
Good afternoon, good morning. This is Felicita Hikwam. I'm the Community Rights and Gender Advisor to the South Africa country team at the Global Fund Secretariat. I just wanted to join the list of speakers who congratulated the HIV sector and or PLHIV sector and the authors, the principal investigators, and the community generally of getting to this point. It has been, I've been somewhat privy to some of the conversations around supporting this work from the background as part of the Global Fund, and getting to this point in partnership with UNAIDS and others, ICW, GNP+, etc. So I wanted to just say very, very big well done to you all. Very excited to see how the use of the findings and the data happens over the next couple of months, weeks, years, and how we can really capitalize on what the findings are telling us, and the partnership to use the evidence that was generated to help remove barriers in South Africa. So once again, just a big congratulations from my side on behalf of the Global Fund Secretariat and the Community Rights and Gender Department at the Global Fund. Over.
Thank you. Last person online. Or your spokespersons are enough. Anyone can respond, colleagues, not only Comrade Blue. Okay.
Thank you very much, Comrade Prof.
Ita.
We also want to say, we welcome, this report. I think, at least, we can see some positives. It's just for us to take this forward and ensure that, all the recommendations that have been put forward, we implement them. It's Thabo Majuja, Coordinating Committee Member, CSF. Thank you very much.
Thank you, Leader. Let's hear from Comrade Mlu and colleagues responding.
Okay, thanks, Prof, and thanks, colleagues, for your positive comments. We have noted your comments as a PLHIV sector leadership. I think these questions, Prof, that have been raised here are not directed only on me, but to all of us as PLHIV Sector. Maybe let me touch on a question that was raised earlier related to a disclosure in influencing the You is Equal to You campaign. I think one thing that we need to admit as a country is that we have dropped the ball around issues of disclosure. In early 2000, we used to go to our communities. When we educate them, we disclose our status, especially those who have accepted their status, in a way of trying to fight stigma, confront stigma, and motivate those who are newly diagnosed so that they can be able to access healthcare services. But we have dropped that ball. I think what we need to do as a PLHIV sector, we need to go back to the basics. We need to go back to the basics and making sure that we integrate the component of a disclosure. And when we do these community outreach campaigns. But doing that, comrades, we need to also respect the right to confidentiality and the right for disclosure, because we can't force people to disclose. We cannot do that because we'll be violating their rights. As much as we need to motivate them to come out so that we can be able to influence the You is Equal to a You campaign. I think the issue of funding cuts by EUSAID through EUS government. One can firstly say this program was funded by a Global Fund, not directly by PEPFAR. As much as there was a hope from our side as a PLHIV sector that PEPFAR will put some resources to complement this study and to design some programs, which is interventions to respond to this. I think, yes, we can admit that it had an impact, the issue of PEPFAR funding cuts. And having said that, we also appreciate the role that our government is playing. But I think it will be important, Comrade Sibongile, to re-emphasize this, that our government is responding very slowly to close this gap. It's responding very slowly. And I think we need to engage more with our government to fund domestic programs, especially interventions like this, because stigma-related programs, especially those that are attached to in the healthcare settings, we are assisting our government. We are assisting our government to close those gaps, because the government alone cannot win this battle. You really need us. But if our government is not ready to support these interventions, who's going to do that? Because it's communities. Stigma and discrimination is happening at a community level. We have here in this report that in the family, in our families, we're still experiencing these problems. So I think our government need to come on board as well to support such interventions. Yes, PEPFAR funding cuts, they have made an impact in all the programs that we've been doing as a country. Hence, we are saying we call on board all the government departments to support such interventions. I'm not sure, comrades, is there anyone maybe want to comment on these questions?
Anyone else, colleagues?
Sister.
Okay. Comments?
Sister.
No.
Okay. Sister is still coming here. You'll include your comments to stand when you are here. Don't worry. Anyone else, colleagues? Or Mlulegu cover everything? Okay. Thank you so much, colleagues. I'm about to call our Deputy Chairperson of people who live with HIV sector. Or you calling it?
Okay, no, Comrade Tando was sponsoring some comment to say we all understand that most of the programs for key population were funded by USAID, which is US government, and they are mostly distracted. Those programs are mostly distracted, so they have impacted negatively, very negatively. Now, key populations are no longer receiving services as the way they used to receive in our communities because of that. And I think, I think there's a private sector that we are not making use of it in this country. We have a private sector within SANAC settings, but we are not making any use of a private sector. I think we need to reach out, Babusuli, to a private sector. They must come on board to fund programs like this, to support the key population as well. Thanks.
All right, thank you so much, Comrade Mlu. On that note, the private sector must really contribute instead of asking money from us. We can't fund business. Like South Africa is other way around. If you move around the world, it's business a contributor to society. But in South Africa, society must contribute to business. Doesn't make sense. Mang Bizo Sistandi, I've written this book, colleagues, and I would like to encourage our leaders to start writing. People don't know who we are, even at SANAC. And I think it's high time that we write our stories. I've started when I was still young, as a boy, being raped at the age of 9, 10, 11. I started there because I had to tell my story myself. And I went on during initiation, failed marriages, everything is here. Because I could sense that if I don't talk about myself, someone will do it for me. So this one, Ekasi stand. She said I must bring it here. It's 350. And there's additional 9 books here. All of you, you can buy. And if they're not enough, you can go online to take a lot. Then you'll get this book there. Over to you, Sister.
Good afternoon, everyone. Thank you, program directors, because most of the time we end up not like Utibanbonge. Thank you very much. We have driven this car very well. Okay, thank you. You know, normally this task, it's like the funeral, Mfundis. You know, when they call speakers to talk, talk about the late. And when it comes to the word of God, it says, I think, 3 minutes. Yeah. They said, we are hurry. Yeah. And the same like this one. And we adopt it because we normally said, I'm here, my task it's very, very, very small. And it's not. To say thank you. It's a big thing, because if you are not here, this launch will be not like happening. Because now we are here, we must say thank you to every one of you who are like be in this launch. So thank you very much to come and attend this launch. I would like also to thank you, to thank the Department of Health. And I also like to thank because you also welcome the reports, which got through when we are going to implement the resolution. There will be no issues of health workers, Dr. Musa. And I also like to thank Comrade Chris from the DSD. You have touched the issue of support group, which is close to my heart. I'm here aging with HIV because of support groups. I'm 50 years this year, aging with it because of support group. And it comes like now, it's like unfashionable. So I'm glad because you have touched that as EDSD, you will come back. And we really, really need you. And I think as you also welcoming our report, I think each and every facility will have social workers where we can go and share our frustration and share our experience. 23 years in my facility, angaze ngahlangana ne-social work, angaze ngarefera ku-social work. I'm at my own. I've been going through no social worker at my facility. But I think because we are here and Comrade Spongile says we must take my numbers. No, Comrade Mlulegi, he's here, he will connect us with you. So I also want to thank our developmental partners and UN agencies, the GNP Plus, and also the SANAC Secretariat, who been coordinating us a lot. And also, I want to thank the HSRC. Godfrey says we are now being like researchers because it was difficult. But the patient that you have, guys, Dr. Lelo, when we are calling, Ma'am Chandi, are you coming? You know, so yeah, thank you very much because we've learned a lot, and you just simplify your science to us as people living with HIV so that we can understand. I think this one we can also do the same as you've done to us to go on the ground and simplify this language. So thank you very much. I will not make it justice if I'm not going to thank, I think they are online, data collectors and the PLHIV sector leaders, provinces. I saw them, Bavela, Ganala, Payana, some, they're from Western Cape, and also the civil society forum, coordinating committee, under the leadership of Ukoko Sheila, chairperson of the civil society, Ubabndugu, Comrade Mlulegi, our chairperson of the PLHIV sector. We thank you, comrades, and also I like to also thank the community. The community, because if we didn't go to them and allow them and trust us with their information, with their information and their stories, this report will be not here today. So thank you very much to all of you, and we are now. This is the end of this this meeting, not of this report. This is the start actually. But for today, we will go out and think how are we going to support, especially DSD and partners who are here, are going to support the PLHIV sector to make sure that this work it's happening on the ground, because stigma is there. I'm not going to repeat it. What Comrade Spongile was saying is stigma is there every day. So we rely on you, Department of Health. We rely on you and all of you. And this is not only for PLHIV sector, as others mentioned. And also, the last, I do this deliberately, the steering committee who are here. Thank you very much for your leadership. And now you are here even today. Thank you very much, because without you, it will be difficult to be chair of the steering committee. But with your support, thank you very much. And so, njoba siphuma manje, let us go and work together to create a society where everyone can live without and access the everyone can live with dignity and access the services they need. Let's break down the barriers and build a stigma-free South Africa. Amandla! Amandla! Thank you.